All right, so we're going to get started. I am very excited for today's talk. I know I get excited every time we have a talk, but we have such an excellent series of speakers. Here we go. So today's title is The Health of Trans Women in San Francisco, and a discussion about changing the status quo to advance health equity. Dr. Sean Arayasirikul is an assistant professor at the Department of Epidemiology and Biostatistics here at UCSF, is affiliated faculty division at the Division of Developmental Medicine, Department of Pediatrics, and senior research scientist, Center for Public Health Research and the Trans Research Unit for Equity, stands for TRUE, San Francisco Department of Public Health, SFDPH. Dr. Arayasirikul is a medical sociologist focused on health equity research. They leverage intersectionality to examine health disparities among sexual and gender minorities of color and develop, test, and evaluate mobile health interventions to improve engagement in healthcare for sexual and gender minorities. Their research examines the impact of intersecting minority, sexual, gender, and racial ethnic identities and their corresponding forms of oppression, misogyny, transmisogyny, homophobia, transphobia, and racism, to name a few, on health and illness. I like to also add that there is a big demand for them on the faculty here at UCSF, and we are excited to see where your career goes. I hear in the grapevine that you got a big training grant, awaiting official notice of award still though. May I say something?
Oh yeah.
Yeah?
Yes, please. Yes.
Great. It's the
And I'll talk a little bit about that too.
Perfect. The National Institute of Allergy and Infectious Diseases New Innovator Award, which is an award for early stage investigators of exceptional creativity who propose novel research concepts with the potential to produce a major impact, test scientific paradigms, or advance key concepts on broad, important problems in biomedical research. Yes, Nikki, yes, I'm so very excited. And thank you, Nikki. Nikki formally invited Dr. Arayasirikul, so we're so excited to have you today. And I do have to do one bit of housekeeping. So at 12:30, Sammy Bona is going to put in the chat a link for registering for today's talk. Please click on it and register so you get CEU credits. And without further ado, please join me in a warm welcome for Dr. Arayasirikul. Thank you so much for being here today. Take it away. I will be quiet now.
Hi, everyone. I'm going to share my screen. So apologies for getting that out of the way. Okay. Do you all see my screen?
Yep.
Okay, awesome. Perfect. Thank you so much, Dr. Stewart. Hi, everyone. My name is Sean Arayasirikul, and today I will talk to you about trans health research in the San Francisco Bay Area. My hope for our talk today is that, what I present to you will hopefully spark a discussion about what the future of health equity might look like, what your role as providers might look like in that, and as also how these particular realities might shape the potential for youth and adolescents that you work with today. Thank you so much for the space and time to share with you these stories of trans health, advocacy, and research. This is a brief outline of what I will discuss today. I tend to be a really fast talker, so I'll try and slow things down. I'll begin with some disclosures and hold space for reflexivity so that you can understand how my worldview shapes the work that I do. I'll discuss the Trans Research Unit for Equity and the tremendous amount of work happening at the San Francisco Health Department. I'll also provide an overview of health inequities that trans women face in the San Francisco Bay Area. And this will include a more focused discussion of young trans women in a study called the SHINE study. At the end of our conversation today, I'll shift towards a discussion to understand and consider what it might take to disrupt health inequity for trans women. And I'll end on hopefully hearing some of your thoughts and questions and on any of the topics that I will touch upon today. So before I jump into my presentation, I find it really important to disclose beliefs and values that my talk is grounded in. I think it's really important to understand who you're talking to, what experiences have led that person to do what they're doing today, and then more importantly, understand what values their work is really rooted in. And first, I believe the personal is political. Here you see that banner in that photo. This is a feminist political slogan that argues that the personal experiences of oppressed people are rooted in their political and social location in society. Our everyday experiences are related to society and those social forces at work at the micro, meso, and macro levels. Second, I believe that centering vulnerability is a legitimate means to reclaiming power. Too many times, too often do minority scholars like myself, do we have to shield ourselves from expressing vulnerability in an effort to uphold the impossibility of being 100% objective. And I believe that your biography, where you come from, your lived experiences, what privileges you've benefited from, this all shapes the worldview and how you approach healthcare and medicine. And I firmly believe that our identities as scholars inform our science from what we study to what research questions are considered important and how we go about answering those questions. I also include this graphic of a trigger warning toward the end of my talk. You will see this again, and some topics thereafter may make you feel uncomfortable. But I wanted to also create space for what those feelings might be and do some work in that space. So so this leads me to share a little bit about myself with you. I'm a queer, non-binary, sexual, and gender minority scholar. This is me. I actually don't know what age, but you can tell I have a penchant for symmetrical wigs. I grew up in a working poor Southeast Asian family on the border of Orange and Los Angeles counties. And when I came out to myself and those around me, I dropped out of college. I survived homelessness after living out of my car for about a year and in Hollywood, California. And during this time, I began to question what I now know as determinants of health and the root causes of social inequity. These experiences have led me back to finish college and then some to serve populations at risk for and living with HIV, primarily young trans women and cisgender men in Los Angeles, Washington, D.C., as well as San Francisco. And ultimately, these experiences have led me here today, honored to be speaking with you, and have shaped my focus on sexual and gender minority health and eliminating health inequities at the intersection of sexual orientation, gender minority identity, and race. And today, I'm a part of the leadership at the San Francisco Department of Public Health's Trans Research Unit for Equity, or TRUE. It's a mouthful. It's situated at the Center for Public Health Research at DPH. And TRUE is a science community partnership whose mission is to generate knowledge and eliminate health disparities in the trans and non-binary communities around the globe. We are a multidisciplinary team of public health professionals, epidemiologists, social scientists, and community members conducting some of the world's most important public health research focused on trans and non-binary communities. This includes the first longitudinal cohort study of risk and resilience among young trans women, 4 waves of behavioral surveillance with adult trans women, psychosocial, digital health, and biomedical interventions to optimize HIV care or prevent HIV infection, global health projects with trans communities in China, Brazil, Nepal, and Portugal, and the first NIH-funded training program to develop the next generation of trans and non-binary scientists and public health practitioners. And I say this, and I share a bit of this to you all because I think that in my experience, sexual and gender minority health is almost always going to be something niche. especially when a lot of my work focuses on the health of trans women. And so I wanted to share a bit of the work that we're doing just to show that there is a lot of work and there's so much work left to be done. And before I jump in, I wanted to lay out a common foundation for terms that I may use in this discussion. Here you have the gender unicorn. It's a helpful, playful infographic that provides an overview of key concepts for understanding gender minority health. And I'd like to highlight some of these concepts. Gender identity is how one identifies, how they move through the world. It's not who one goes to sleep with, but who one goes to sleep as. And this can be within the gender binary, somewhere on the gender spectrum, or outside the gender binary entirely. Gender expression is how one demonstrates their gender, how one acts, dresses, behaves, or interacts. Sex assigned at birth can include male, female, intersex, or other. And physical and emotional attraction can contextualize one's sexual orientation and be directed toward men, women, or people of other genders. One's attraction can vary in strength and or be non-existent altogether. And I use the phrase trans woman or trans man to refer to folks whose gender identity is not that which is typically associated with their assigned sex at birth, but who identify within the gender binary. I use the term non-binary to describe trans people who do not identify within the gender binary. And I use the term cisgender or cis to describe people who are not trans. And the key takeaway point here is that gender is a social construct. There are no predetermined links or associations between one's gender identity, their gender expression, their sex assigned at birth, or their sexual orientation. It is in the preconceived assumptions about these associations between that serves as the basis of transphobia and anti-trans stigma. Next, I will attempt to take on the daunting project of describing in broad strokes the unique history of trans health research in San Francisco, with a focus on what inequity in trans health looks like. The first broad population health study focused on the health of the trans community was conducted in San Francisco in 1997. The Transgender Community Health Project, TCHP, was a result of the advocacy of local trans health leaders who partnered with the San Francisco Department of Public Health to conduct the first community health needs assessment of its kind. The study was guided and staffed by community members and took place at local CBOs. The study recruited a large sample of trans women and men in San Francisco. The study found that among trans women, there were high levels of lifetime HIV risk behaviors. This included sex work, unprotected receptive anal sex, and injection drug use. Over 1/3 of trans women were living with HIV at the time, and it found that HIV disproportionately impacted Black trans women in San Francisco. And among trans men, the study found that HIV prevalence and risk behaviors were low, and about 1 in 5 trans men had a history of injection drug use. And of these, nearly all reported having shared syringes. And this body of trans health advocates that led up to that study, that led to the creation of the also led to the creation of the Transgender Advisory Group at the San Francisco Department of Public Health. More than 28 community-based organizations, local government offices, and community advocacy organizations came together to form the Transgender Advisory Group, or TAG. Its mission at the time was to provide guidance to the HIV Prevention Planning Committee for the San Francisco MSA and the AIDS office at the health department to improve services for the trans community. With these important data in hand from the first large community survey of trans people's health, they fought to include trans people in key populations at risk for HIV and help shape the evaluation and care of trans people in the public health system at large. And for the next 20 plus years since 1997, there has been sustained investment in the public health of the trans community. I've been involved in more than 10 social epi studies of trans women in San Francisco and globally. We've conducted 4 waves of the TEACH studies using the same model of community engaged research from the 1997 Trans Community Health Project study. And our groundbreaking work with the TEACH studies has led to the CDC's inclusion of trans women for the first time in the National HIV Behavioral Surveillance Study in 2019. We worked with young trans women ages 16 to 24 in the first longitudinal study of risk and resilience called the SHINE study, where I developed new methods to adapt respondent-driven sampling and social media technologies. We also developed a new novel sampling methodology to recruit trans men in public health research called starfish sampling. It's a hybrid of venue-based and respondent-driven sampling in a study called the STRIPE study. And lastly, but not least, we've developed global cohorts of trans women in Sao Paulo, Brazil, Nanjing, China, and conducted the largest study of health of trans women in Nepal. Not only does this research describe and measure changes in trans health over time, this research has enabled us to estimate the size of the population of trans people in San Francisco. And with these data, we've been able to understand the extent to which health disparities exist in the trans community. And more importantly, we can shape priorities in public health and influence how funding is allocated. So who counts? How many trans people are there and who is impacted by HIV? Using data from the TEACH-2 study, we estimated that there were 978 trans women in San Francisco with an HIV prevalence of 39%. Data from the STRIPE study indicated that there were 806 trans men in San Francisco and an HIV prevalence of 0%. And as a starting point, this is helpful. This is really insightful data. However, if we look at the HIV incidence data from 2019, it shows that 7% of all new HIV diagnoses were among trans women, and 1% of all new HIV diagnoses in 2019 were among trans men. So altogether, these data point to a number of possible conclusions, that the profile and social context of HIV risk in San Francisco is changing, and HIV risk among trans women and trans men is steadily increasing over time. Not only is HIV infection an important trans health issue, engagement in HIV care is also critical. And what we've seen is marked gaps in the HIV care continuum, with 14% of participants living with HIV in the TEACH-3 study reporting that they were not engaged in HIV care, and 13% not currently taking antiretroviral therapy, and more than a third either reported a detectable or unknown viral load, leaving a lot of progress and a lot of work ahead of us to provide health outcomes, positive health outcomes, and positive quality of life to trans people living with HIV. Aside from HIV infection and HIV care, we've also observed disparities that are intersectional. In one analysis, I found that adult trans women who reported high levels of anti-trans discrimination had a greater likelihood of engaging in binge drinking compared to those who reported a low level of anti-trans discrimination. And we found that experiencing anti-trans discrimination and racism led to increased odds of not being engaged in HIV care. These findings demonstrate that even among a vulnerable minority community like trans women, those at the intersections of other marginalized identities, those who may be visibly trans and ethnic racial minorities, are at elevated risk for poor health. So next I'll get into, I'd like to dedicate some time and space to tell you more about the SHINE study, the first longitudinal cohort study of risk and resilience among young trans women in the San Francisco Bay Area. The SHINE study sought to address specific knowledge gaps in the health of young trans women. And at this time, studies suggested that 1 in 5 trans women were infected with HIV before the age of 25. At the current state of the science, and the current state of the science was biased and limited, as previous studies often lumped trans women with gay, bisexual, cisgender men. And in part, this may have been attributable to the stark dominance of HIV in the larger discourse of trans health, with much of the literature centered around heteronormativity and heterosexuality. And the SHINE study sought to expand what we knew about young trans women, offer new theoretical perspectives, and understand the health issues affecting them most, as well as really creating an opportunity for the trans community to show their power and share their stories with a larger audience. The SHINE study was a longitudinal cohort study of HIV risk and resilience among 300 young trans women ages 16 to 24 in the San Francisco Bay Area. Recruitment took place between 2012 and 2014, and the study went on till 2016. I used respondent-driven sampling, but also developed a comprehensive social media recruitment strategy to recruit participants. We used a secret Facebook group and social media platforms to retain participants over a 24-month period. And participants completed behavioral assessments and HIV testing at baseline and every 6 months thereafter for 2 years. And this is some of our recruitment materials from young trans women leaders in San Francisco. One on the left is Aria. She is the executive director of the Transgender Cultural District. And it's been an honor to really be a part of so many young trans women's lives as a part of the SHINE study and see where they are now and the heights that they're reaching now. This was the first and largest study of its kind to recruit and follow a cohort of young trans women over a 2-year period. And for this reason, you may be interested in the recruitment methods we undertook. I won't be able to go into them in much detail, but I've published 2 papers that describe and examine these methods more closely. The first in AIDS and Behavior, and the second in the Journal of Medical Internet Research. Especially as technology, pre-pandemic, the interest in technology has risen and exponentially since the pandemic. I wanted to include this just to kind of offer that there are a lot of ways to use social media technology in well-established methods. Next, I'll present some data on the diverse gender transition journeys of young trans women in the SHINE study. First, I'll start with social transition. And by social transition, I mean feeling and living as trans and disclosing one's identity to one's social circle. So here, this figure describes the varying degrees of social transition among young trans women in the SHINE study. And I apologize in advance, the text is small and some of the bars in the histogram don't line up perfectly, but I will walk you through it. Here in the highlighted box, you see that about a third of participants reported feeling trans by the age of 5, and a little more than a third between the ages of 6 and 12. The mean age, not pictured here, at which participants thought they were trans was 8.9 years. Here, you see that the majority of young trans women started living as trans in their adolescence and young adulthood, and the mean age at which participants reported living as trans was 17 and a half. The majority of youth, about 46.5%, who were currently living as trans, reported waiting 10 or more years before living as trans. And the majority of young trans women who were currently living as trans had socially transitioned in the last 5 years or less. We found that 60% of young trans women came out as gay as their identity before identifying as trans, and most were out to their social circle as trans. And I want to say that the San Francisco Bay Area is really unique in regards to its history around the LGBT and queer communities. And so this may be the last data point around most young trans women being out to their social circle as trans. I think that that's something to keep in mind, and that may not be representative of other parts of the country, especially today. And next, I'll walk you through some medical transition milestones in the journeys of young trans women in the SHINE study. And this figure here, just to orient you to this figure, there are two types of bars. The patterned bar is the prevalence of young trans women who reported a specific medical transition milestone. So that's the overall prevalence in the sample. And the solid bar is the prevalence of a specific medical transition milestone among those who specifically desired this type of gender-affirming healthcare to support their medical transition. So I'll break this down a little bit further with some examples. So here you see that in the pattern bar, overall, 16.3% of young trans women in the SHINE study reported ever taking puberty blockers. However, seen through the lens of those who desired taking puberty blockers, who wanted to take puberty blockers, this represented 19.1% of those young trans women. So for now, let's just focus on the patterned bar or overall prevalence. A little over half reported currently taking hormones at the time of their participation in the study. A greater proportion of young trans women started taking hormones between 21 and 24 years old compared to 17 or younger, and between the ages of 18 and 20. And about 30% of young trans women had reported having a gender-related surgery or procedure at the time of participating in this study. And if we return to the solid bars that report the prevalence of a specific medical transition milestone or service among those who desired it, reporting these data, I just wanted to say that reporting these data this way is really intentional on our behalf. It centers the notion that not everyone's gender-affirming healthcare or medical transition will consist of the same steps or the same milestones. The transition journeys of young trans women are incredibly diverse. And in addition, across all these medical transition-related steps, you see that we've observed that none of these are at 100% among those who desired it. So this highlights this great unmet need of young trans women and their medical transition medical transition related healthcare, as well as the social inequity and potential barriers to accessing gender affirmative healthcare that young trans women face today. And our findings from the SHINE study also found that high levels of transphobia or anti-trans discrimination was significantly related to greater odds of PTSD, depression, as well as mental distress related to suicidal thoughts. Young trans women who experienced transphobic verbal abuse were more likely to use non-prescribed hormones, and parental closeness and parental social support, while low overall, may lower odds of poor mental health and psychological distress. We also found that compared to white counterparts, young trans women of color were more likely to identify within the gender binary or use binary terminology to describe their gender identity, as well as their sexual orientation. What this means is that young trans women of color were more likely than their white counterparts to identify as trans women or female, as well as heterosexual. And so there was more diversity around white young trans women. Sexual minority, we also found that sexual minority trans women had greater odds of reporting recent heavy episodic drinking and illicit prescription drug use compared to their heterosexual counterparts. So what will it take to disrupt inequity in trans health? There have been some notable cultural shifts in San Francisco and society at large. The creation of the tag was a major milestone that still exists today. The tag has informed all of the following initiatives I will talk about. The San Francisco Department of Public Health developed the first gender-affirming care access and navigation hub in 2012. the San Francisco Department of Public Health also developed and adopted guidelines for collecting data on sexual orientation and gender identity across all publicly funded health services. And as you can imagine, this initiative alone created a need to build the organizational capacity and skills to provide culturally competent and affirming care to trans people. And in 2013, gender identity disorder was removed from the DSM-5. At True, we've launched a number of initiatives to address disparities in trans women's health. We developed the Brandy Martell Project, a group-based legal empowerment workshop series, and provided access to free legal services to improve trans women of color's engagement in HIV care. We've developed text messaging interventions to help young trans women living with HIV stay connected and engaged to HIV care. We've also developed social media campaigns to increase awareness of pre-exposure prophylaxis, or PrEP, which is a daily pill to prevent HIV infection among the trans community. And in this study called the STAY study, we also engaged 4 community health clinics to build their capacity to prescribe PrEP to trans patients. And we've even developed the first NIH-funded training program on training the next generation of trans and non-binary population health scholars called Shine Strong. However, despite all this, and unfortunately, change happens in very small increments. And I include a trigger warning here as the next set of slides discuss violence against trans people and can be upsetting. This is Desaya, the 35th trans person murdered this year in the United States. She was murdered last week on Labor Day. And 2021 is on pace to be the deadliest year for trans people, especially trans women of color. And in 2019, Leilene Extravaganza Polanco was held in solitary confinement at Rikers Island in New York. She experienced a sudden unexpected death related to an epileptic seizure. However, video footage later revealed that when guards responded to her cries for help, they laughed and waited 90 minutes before calling for assistance. She died an hour later. 2 days after the murder of George Floyd, Tony McDade, a Black trans man, was killed by the police in Tallahassee, Florida. And this is Aubrey Mariko Shine, who is an SF Bay Area trans advocate. In 2015, Aubrey was 22 when she committed suicide by jumping off the Golden Gate Bridge. And when I reflect on what's needed at this moment in time to change this systemic devaluation of trans people's lives, I think it's obviously more than health and healthcare and access to gender affirming healthcare. I'm reminded about the impact that spurred from the Transgender Advisory Group. We need more trans-led policies, leadership, and organizing. This is a map of the transgender district that I referenced earlier in my talk. This is the first legally recognized trans-specific cultural district in the world. It's located in San Francisco's Tenderloin area. The transgender district is a well-documented home for trans residents in San Francisco. And its current initiatives include a social media campaign to embolden a sense of history, ownership, and belonging of trans people in San Francisco. They also have initiatives focused on community beautification and financial investments in trans-led small businesses housed and homed in the transgender district. And I think we need more cross-sector innovation and large-scale investment in entities like the Transgender District. This is Raven Saunders, American winner of the silver medal in women's shot put at the Tokyo 2021 Olympic Games. And when asked about her podium gesture, what her podium gesture meant, she said, "This is the intersection of where all people who are oppressed meet. And while I may not know exactly what we need to change the course of anti-trans stigma or discrimination and violence, I'm confident that the solution will involve us working together at the intersection where all people who are oppressed meet." And I wanted to end on a point about the trajectory of my talk today. I think that focusing on purely one developmental stage or one specific topic area that impacts young trans women's health is going to be too short-sighted to understand the reality and the social world that we live in when it comes to trying to unpack and deconstruct what transphobia in society actually is today. And so while you all may interface and work with and serve sexual and gender minorities that are also youth and young adolescents, I would urge you all to think about the world that we live in and the kind of reality that these young people are stepping into and what kind of potential for health exists, especially if we don't value the lives of trans people, and even more so, we even more so those at the intersection of race and gender identity. So I wanted to thank you for your time, and I know that I've presented some data that you might want to revisit. So at this point, I'd love to stay in touch. Please, here's my email. Please contact me, and I'd love to have some time for questions and hopefully a discussion and in terms of how this work that I've presented may intersect with yours. So right now, I'll go ahead and stop that share.
Thank you so much. Lots to think about, very powerful presentation, and highly data-driven, so important, right? I love the point you made at the very beginning, which is if you're not counting it, then you don't care about it,
Absolutely.
right? So thank you for that. I'm gonna open up the floor or the Zoom room for questions. You're getting lots of accolades and appreciations. Please feel free to unmute yourselves to go ahead and ask a question. Anne, go right ahead.
Thank you so much for this wonderful presentation. I'm new to San Francisco. I had no idea that there was actually the first trans district in the world in Tenderloin, and that makes me feel proud to be now in San Francisco. I guess one question that I have for you is we really lack epidemiological data in the United States, right? Most of the data that we've used as clinicians that were not necessarily specialized, like generalist clinicians, come from Scandinavia. And I want you to comment, like, whether you have an idea about some of the prepubertal data that you presented, because I think it's incredibly important, this finding that there are these early, gender affiliations that are different than the gender that you're born in. I think what I would want to know as a clinician is, do we know how many kids have that and then proceed to sort of leave that behind? Because that's an important finding from Scandinavia, is that the stability certainly in those samples, are much higher after puberty. And so just anything you can tell me about that and the group would be amazing.
Absolutely. I think that one of the privileges of looking at data from different cultural and international contexts is that we can actually look backwards and look at kind of in context of those cultural practices and histories, we can understand the natural experiment of what it might look like if the United States were a country that supported young trans people and the transitions of young trans children, right? And so that's the data that and thank you for this question that you're referencing. And so I think that to answer the question from the perspective of a United States context is that a lot of our data are actually focused on HIV and focused on anti-trans discrimination and violence. And so there are actually very few data repositories and or consistent data evaluation efforts and data measurement efforts to actually work with young trans children. And so in the Bay Area, there's actually an organization called Gender Spectrum. It is an organization that is specifically centered on training mental health professionals and clinicians in and around their ability and skills to support young trans children. And so I think that while we don't have the data on, at least we don't have the data here in San Francisco either, but I haven't seen US data on the interest in, but also the access to puberty blockers. A lot of that access is really through word of mouth, based on parents and the kind of systems and healthcare systems that our parents are enveloped in. But also there is a long-standing belief that young children are unable or unable to actually know who they are, and this doubt is very predominant in right-wing critiques of trans identity. And so I think that one of the questions for you all is that when you work with young kids, we know that young kids know who they are. And so I think that that fear around that self-determination can be harmful. And so there have been studies looking at what happens if trans kids do actually start hormones later. And there have been qualitative studies trying to understand what that process looks like. And so when parents actually withhold transition from a young trans child, that actually going through that, going through the puberty of the gender with which they don't identify is quite harmful psychologically. And so there have been some qualitative studies that have looked at that impact on the mental health of young trans people, kind of wanting to provide some more evidence and support for allowing access to puberty blockers and cross-sex hormone therapy at younger ages. And right now it's really, clinician-based, and the guidelines around that can be thwarted, based on where someone lives and who their provider is and who their parents are. If that home environment isn't affirming, there really isn't any. You could imagine that measuring the prevalence of puberty blockers among trans kids might be really biased and underreported.
Oh, sure. No, I think, and I want to let other people talk, but I think I did work with a lot of parents who were Republicans. I just moved from Missouri.
Ah,
I think my question was more that, in a sense, the data is what you're saying is, I think, absolutely uncounterable, that if you take adolescents and you try to suppress their transition, it's bad. We have these huge data that show that. I think it gets more tricky when you're talking to Republican parents, which maybe,
oh, absolutely.
but it gets more tricky when you're talking to people who are very conservative.
Absolutely.
We don't have large scale data that in a sense is as clear, is my point. And so I really appreciate you providing us with some data. So
Awesome. Thank you, Anne.
Relatedly, I wonder if there's some piece of data that we can call upon to help parents feel more comfortable about seeking puberty blockers. For example, like how many would you know this? How many children don't go on? I know this is layered,
Yeah.
but don't go on to proceed with another process or another mechanism by which they feel more comfortable in their bodies. Like I'm just guessing that if there's a low number, right, that would give caregivers solace, like, oh, this is not a temporary state of like figuring themselves out and they don't know, do you understand what I'm getting at?
No, absolutely. Yeah. And I mean, unfortunately, this is the data that we're discussing now is really nascent, and so and if you know, if even available at all. And there only, I think only about 3 years ago has there been a large enough representative study of trans people in the United States that was conducted at the Williams Institute at UCLA. And so you know, we're really behind with regards to our thinking about how to best provide a data-informed care, you know, path toward gender affirmative care. But we do know a lot about what doesn't work. And so while we may not have data exactly characterizing the pathway that we're talking about now, we do know that non-prescription, there are risks around non-prescription drug, non-prescription hormone use, and that is quite prevalent among specific communities. And so, and as well as other practices like using fillers to change one's body. And so we do know that there are other behaviors that people undertake that are harmful. And so that kind of engages with this conversation about, well, how do we actually get the right, safe access pathways to support the wholeness of trans people?
Thank you for that point. Mags Hines, you have a question? Feel free to unmute.
Yeah, so I was curious, given that the nature of most trans healthcare in this country still is based around gatekeeping and how a lot of trans people have to kind of create a narrative of themselves that fits for the more modern medical conception of what it is to be trans, vis-a-vis having a set identity at, say, youth when you're trying to access blockers. I'm curious if you have any data on the kind of alternative pathways that people approach to get care, the stories that we create in order to get around these still extant barriers, especially I think still in San Francisco, and how those kind of bottlenecks of identity and care pathways end up biasing these data. Does that make sense as a question?
Absolutely. And unfortunately, there are really disparate worlds here. And so I have, you know, me being at the public health department and in a social epi shop where much of this data is coming from, we actually don't do as much qualitative work that we ought to be doing. My colleague, Chris Hansman at SF State, actually has done some work around this exact topic of trans people, of the ascendancy of gender affirmative healthcare, what kind of beast it's become and how it does implement these kinds of gatekeeping practices. And I think that that is at the crux of much of the challenges that we have. They're intersecting, I think, with relationship to, I think that these gatekeeping practices are very much related to autonomy, very much related to self-determination, and very much related to, you know, and linked to anti-trans discrimination in the United States as we know it. And so while I don't have that data, I'm really happy that you brought that up and that you're interested in it. And hopefully others, you might want to check out work from other scholars as well in this area.
Thank you.
Thanks, Mags.
Sean, could you reshare the last name of your colleague, Chris, at SFSU?
Yes, Christoph Hansman, Hansman. I believe that's how it's spelled. Hansman.
Go ahead, Nikki.
Thanks. As usual, super awesome presentation.
Thanks, Nikki.
Can you help us think, for folks who are involved in clinical research, some low-hanging fruit you might encourage folks? Obviously, the questions that just got presented take really thoughtful expertise and big grants to really dig into some of this nuance. But is there something you might encourage everyone to incorporate in their research? Obviously, gender identity at a really young age, not making assumptions, by parent report, those types of things. Is there a few low-hanging fruit you might want to fertilize our brains with in this context?
Yeah, I mean, so there are two thoughts. I think that reflexivity is really important. And I think that maybe with this group, I'm preaching to the choir, but among most quant-heavy shops and epidemiological scholars, that reflexivity and positionality is quite odd. But I think that starting there and being reflexive of one's positionality, I think really helps, and it really unpacks the potential for understanding what might be the barrier and the key that we need to, and the lock that we need to unlock with regards to understanding anti-trans sentiment. Of course, I think being, even as I've said that, I mentioned that the San Francisco Department of Public Health also developed guidelines around the collection of SOGI data, sexual orientation, and gender identity data. I think that differs in its in the context of depending on where you are in the system. And so I think that's still an uphill battle. And I want to say that collecting data is an opportunity to have a conversation, right? So asking someone their pronouns, asking someone their gender identity, and not making those assumptions is an invitation to have a conversation. And I think it's within those conversations where we can really explore and unpack. And I think that I understand that there might be some hesitation in being able to have that conversation, especially if you haven't served sexual and gender minority youth and gender identity minority youth. But having that conversation, I think, is a way for young trans people to be seen. And I think that at that age, that opportunity and that impact really outweighs any one person's kind of feelings about feeling inadequate about having that conversation. I also think that, when I think about the tremendous amount of violence that's directed towards trans women of color, I think that that's something that whenever I talk to new audiences, they're always really kind of aghast at that happening, as well as just the high prevalence of HIV among the trans community. And so those are kind of emotions to have, those are legitimate emotions to have, but to understand why, I think, is really important. Why the surprise, or why not the surprise? And so I think that a lot of what I find myself really trying to unpack are those feelings, because I think those feelings are really rooted they're really at the root of this anti-trans stigma and anti-trans discrimination that we're seeing today.
But do you think that they're also, so I don't know if you were making a comment about clinicians and what we ask and don't ask, because I agree that in a sense, I was thinking about IRBs and how when I wanted to ask kids if they identified as gay, that was considered really high risk, And one of the question was, do you systematically do that clinically? And I was like, yes. So then, but in general, there's tension even there. I think in situations where you suspect that the family will be hostile, it's a little bit complex in a sense to obtain this information and then feed it back to the family, unless you have a very specific plan on how to make that family higher functioning, which may be very different in some parts of the country. So I can tell you that's also part of the issue, and that may be the
It
same.
can also be very irresponsible to collect data on something
Absolutely.
sensitive if you don't have a clear sense of how you use it. And so I guess that's why I was grateful for Sean's reflection, because there isn't some default where we should now ask every child their gender identity in our research study and everyone their sexual orientation, just to be inclusive. Because I heard Sean say, and correct me if I'm wrong, that it's nice to be seen and asked, and yet if there's any risk to that child for disclosing, or if the parents are going to freak out and want to see results of that type of thing, maybe it's not worth it if you don't have a plan for how you'll use it. So I think we don't know totally yet, but it is good to be thinking about whether or not it makes sense.
Yeah. Coming from a part of the country where, some people are praying.
Absolutely.
Some people are, I would say that, and with some of the data that we have, that certainly lack of family support, family hostility towards gender orientation or trans status is a very clear risk factor for depression, suicidality, etc. I think that that's a very important part of research agenda moving forward is to figure out, and clinical agendas too, how
Absolutely.
to make this work.
Absolutely. And I think that so much focus has been attributed to trans people themselves. But when we're trying to change the health outcomes of trans health, it's actually has very little to do with trans people themselves. It's about the people that are actually there to hurt them or to withhold from them or to see them as completely invisible. And I just think that that's if folks are interested in thinking about that, I'm trying to unpack what that might look like, what approaches might be helpful or even or hold water with parents. But and I think that we have the opposite kind of privilege here in San Francisco is that many people come here, many trans people come here for acceptance and find some semblance of acceptance, but there's no social systems to actually support them through their lives. And so, yes, coming out is, I think, absolutely one of the most individually tricky things to endure, not only within a family context, but especially with a provider. But if folks if folks have worked with parents and would like to explore some of that, I'd love to have a conversation about that too.
Count me in.
Awesome.
And this gets particularly tricky when you're writing, in the medical chart, right, for a child or teen who has yet to come out and cannot.
Oh, absolutely.
Right? Because of family differences and, family differences. And so we, on our side, clinically, we often struggle when we provide, because we provide like feedback letters for an evaluation, right? We want to use the correct pronouns when referring to the child. So the best that we have been able to do is just use the name over and over, right? Like where you would put a pronoun, you put the name down, written down, typed down, so it doesn't cause problems for that child with their parent, or that they're not like they don't have the support to have a discussion with. I mean, does that make sense?
Oh, absolutely.
And that's so telling, right? We're in a don't ask, don't tell.
Yes.
And it's wonderful you're making us think about that, because I think we all operate from a do not harm the patient, right?
Sure.
And I think in a sense, what's provocative here and important is the idea that, like, how do we bridge with parents of different ilks so that in fact maybe part of our health behavior is really being attentive to the fact that there is this process for the child, and that on one hand it would be important for them to have a trusted adult that they can talk to. On the other hand, they're minors, right?
Yeah.
So it's a lot to think about. It's a great presentation.
Yeah, I especially appreciate your balance of just rigor in the science and the data approaches and the qualitative mix with the quant, and then your reflexivity and your modeling of disclosures and reflection. It's a really good example for us to learn from.
Thank you, Nikki.
It's also, I feel like as a science, you may, this may be a stereotype, but I'm just speaking out loud about my observation that I think scientists in the area of transness, at least the younger scientists, are often also activists, which is almost like a new species of science, because frankly, those two things do not always go together. And so there's a lot to understand.
Absolutely. No, I think that this may be on a different chord, but all that we do to try and be objective, especially those that I engage with every day, is really useless. If we've learned anything from the last few years, it's actually we need more skin in the game. We actually need to bring our complete and whole selves to everything we do, rather than try and hide it. Yeah. Thank you, Anne.
Yeah, neutrality is fake, false, doesn't exist.
Yes, absolutely.
Thank you.
Yeah, thank you, everyone.
Thank you so much. And I can't wait to hear more from that big grant. You get big data out of it, and come back next year to tell us about what you found. That's an open
Awesome.
invitation.
Whenever you're ready.
No pressure.
All right.
Thank you, everyone. Have a great afternoon. Take good care. Bye.
Bye.